Bismillahirrahmanirrahim. Today, our first question is a 20-year-old woman books in an antenatal clinic at 13 weeks of gestation. She has a pap smear done 1 week previously, which showed grade 3 cervical intraepithelial neoplasia. Grade 3 cervical intraepithelial neoplasia. Which one of the following is the most appropriate next step in management? So this is a young 20 years old woman which has presented at 13 weeks of gestation, and pap smear was done 1 week previously, which showed uh, CIN, cervical intraepithelial neoplasia. Which one of the following most appropriate next steps? Cervical intraepithelial neoplasia means it's a grade 3, means this is a full thickness of cervical surface layer which is affected by the abnormal cells. So SYN3 is also called carcinoma in situ. This sounds like a cancer, but SYN3 is not a cervical cancer. Cancer develops when the deeper layer of the cervix are affected by the abnormal cells. So at this stage, which one of the following the most appropriate next step in management? So we'll go to the options. Uh, Number one is a termination of pregnancy and colposcopy and cone biopsy, colposcopy and large loop excision of the transformation zone, Leeds biopsy, that's also called Leeds biopsy, and another is repeat the pap smear at 34 weeks of gestation. So we would exclude one by one as a termination of pregnancy here. With this early stage of means changes, we will not go with the termination of the pregnancy. So A, I would exclude. Remaining colposcopy, that's the next step. Whenever we see the SYN3, we have to go for the colposcopy, and colposcopy is also uh, is not contraindicated while in the pregnancy or at the age of 13 weeks of gestation. So we will keep this colposcopy as the best option. Another is a colposcopy and cone biopsy. Cone biopsy we will do later. Before that, we have to do only colposcopy and repeat the pap smear at 34 weeks of gestation. That's also we would not choose, because we will not wait for the 34 weeks of gestation. Why to wait? uh, Before that we have to go with the colposcopy. So I think colposcopy is the best option to choose in this situation. The correct response is the colposcopy. Providing the lesion does not extend up the canal out of the view of the colposcopy, cone biopsy, large loop excision of the transformation zone biopsy are not indicated. Termination of the pregnancy is also not required. Repeat pap smear is best done after the pregnancy has been completed, because repeat colposcopic assessment during the pregnancy provide all of the information required. A decision concerning the final treatment required is not usually made until the postpartum visit, unless a colposcopy suggests an invasive cancer at an earlier time. So the next option will be to do the colposcopy, and then accordingly we will decide the further stages, how we can plan further. Next question, a 42-year-old liar present with an 8-week history of pervasive sadness, bouts of crying, anorexia, and weight loss, a feeling that his life is not worth living, fatigue, and disrupted sleep. Of which one of the following abnormal sleep pattern is the most likely to complain? 42-year liar with the present with the complaint of bouts of crying, anorexia, weight loss, or feeling that his life is not worth living, fatigue, and disrupted sleep. So, which of the following abnormal sleep pattern and most likely to complain. Difficulty in initial sleep, dreams with a content involving death of the patient, early waking after initial sleep, somnolence in the early part of the day, oversleeping. Means which one of the following abnormal sleep patterns is he most likely to complain? So the sleep disturbance is a core feature of most cases of major depression, with over 90% of patients being affected during EEG criteria. There is a disruption both in overall sleep pattern and in the architecture of the sleep achieved. Typically, there's a middle insomnia, waking up during the night. That's called middle insomnia, waking up during the night and then having a trouble getting back to sleep, and if successful, having a broken sleep thereafter. Initial insomnia or increased sleep latency and difficulty falling as sleep may occur, but this is more commonly associated with anxiety or the use of nocturnal stimulants such as caffeine. Terminal insomnia means both early morning wakening and being unable to get back to sleep at all. Hypersomnia and oversleeping is much less common in depression. Oversleeping may include periods of daytime sleeping as well as prolonged nighttime sleeping. Dramatic dreams, including dreams about death, are not typical of depression. With normal sleep onset, slow wave deep sleep occurs early on the periodic rapid eye movement sleep phases during the night, which increases in frequency after 5 hours. In major depression, REM sleep occurs sooner after sleep onset, and slow wave sleep increase as sleep progresses, which contributes to both early awakening and subsequent broken sleep that is unrefreshing. In patients with major depression and insomnia, mirtazapine, venlafaxine, and sedative tricyclics such as trimipramine and clomipramine may be the first choice of treatments. Some of the selective serotonin reuptake inhibitors, antidepressant, may be more stimulating and energizing and cause nightmares, aggravate insomnia. One should always include sleep hygiene principles as well as antidepressant therapy in treatment of patients with depression, and consider other causes of insomnia in the differential diagnosis, for example, substance abuse or obstructive sleep apnea. So the correct answer is the early waking after initial sleep. Means this early waking after initial sleep is one of the complaint patient will have. Means this will be the abnormal sleep pattern in this patient. Early waking after initial sleep.